This is a video illustration of the surgical technique paper Hip Arthroscopy for Femoral Acetabular Impingement, an innovative bird's eye/on-face perspective with ultrasound guidance and three-dimensional hip printing. The patient is placed in the lateral decupitous position with the operative side facing up. The Smith & Nephew hip positioning and active heel traction system are employed. The regular anterolateral portal and mid-anterior portal are created. Occasionally a medial portal is also used when the pincer lesion labral disease extends beyond the psoas recess to give a better angle for anchor placement. A scope is placed in the anterolateral portal and the mid-anterior portal is created under direct vision. After portal creation and interportal capsulotomy is completed by interchanging the camera and samurai blade from both portals. With the scope in the anterolateral portal and with a slingshot device in the mid-anterior portal, a traction stitch is taken in the capsule adjacent to the labrum, allowing for capsule retraction and better visualization of the labral pathology. A thermal ablation device is used to carefully separate the capsule-labral junction until the pincer lesion is identified. As per our preoperative planning with a three-dimensional hip model, we can visualize the pincer lesion extending to the 4 o'clock position beyond the psoas recess. This corresponds to our intraoperative view. The inferior aspect of the pincer lesion is confirmed both extraarticular and intraarticularly by pushing against the labrum and viewing the chondrolabral junction. The pincer resection is performed with a 5.5 mm arthroscopic burr, starting inferiorly and progressing anterolaterally. From our preoperative plan on the 3D hip models, we can visualize a type 2 subspine impingement and the pincer lesion extending to approximately the 12:30 clock face position. The subspine impingement and the lateral aspect of the pincer is visualized best from this view, the bird's eye view. The subspine area is decompressed and pincer resection is completed up to the 12:30 position by identifying the chondrolabral junction. The labral repair is performed in the usual fashion, starting medially and progressing anterolaterally. It can be seen that sutures are spaced equally and the labrum is well secured against the acetabular rim. After this, the hip is reduced to confirm an adequate labral seal. Now we will proceed to the cam resection, and again, we can visualize from the 3D models the medial extent of the cam on the on-face view. The hip is abducted and flexed. Viewing through the anterolateral portal, the scope is driven anteriorly to identify the medial extent of the cam. From the bird's eye view, the cam lesion can be seen extending to the 12:30 clock face position. The same can be confirmed from the arthroscopic view. The cam is outlined using a thermal ablation device, starting from the anterolateral aspect and extending medially. The cam resection is completed with a 5.5 mm arthroscopic burr using the thermally ablated borders as a guide for resection. Care is taken to avoid any spurs or divots. From our preoperative planning on the 3D model, we can actually see the cam deformity extending laterally on the femoral neck. We find this helpful in achieving a smooth resection and level with the adjacent femoral neck areas. After we are satisfied with the extent of resection, the neck is visualized all around to confirm adequate resection in relation to the labrum and adjacent neck. This concludes the surgical illustration utilizing the 3D hip models for femoral acetabular impingement.